to the Orthopedic Tutor channel. In the last video, I have discussed extensively about the spondylolisthesis regarding its basics and its concern in the sagittal balance, and also regarding the pediatric or adolescent type of spondylolisthesis. Today, I would like to discuss more about the adult isthmic type and also the degenerative type that is more commonly seen in the population. So for the first one would be the adult isthmic type. For the adult isthmic type, the etiology may be somewhat similar to the ones in the pediatric population, which involves repetitive hyperextension movements that are seen in certain populations, such as gymnasts, weightlifters, or football linemen. Well, although not exclusively due to this, some may be caused by an increased pelvic incidence and also increased sacral slope, which in turn increase the lumbar lordosis. And this translates into a more simple language. If there are increased lumbar lordosis, then there is also an increased shearing force over at the spine. And as there is increased shearing force, the spine could be translated anteriorly even more easily compared to those with normal lumbar lordosis. Well, the diagnosis always includes history taking and additional physical findings. For the history taking, patients with spondylolisthesis may present with radicular findings. They could also present with a low back pain due to increased strain in the various ligaments or joint capsules that hold together all those structures. Neurogenic claudication may sometimes be found if the listhesis or the slippage is great enough and acute enough to occlude the posterior structures. So for the radicular findings, there is a term called Gill nodule. The Gill nodule is actually a radiculopathy that occurs due to the compression from the fibrocartilaginous tissue that is formed due to repetitive pars injury. As going back to the initial imaging here, we could see that this zone is called the pars interarticularis, the region between the inferior articular facet and the superior articular facet. And in patients with increased lumbar lordosis or repetitive hyperextension injury, this area is the area which sustains the greatest force, and repetitive microfracture may occur and is followed by fibrocartilaginous repair tissue, and this tissue may sometimes enlarge, forming a Gill's node, and this node can cause radiculopathy. Well, moving on to the management, you should check out my previous video regarding the management of other subtypes of the spondylolisthesis, but basically it's all the same, because if the patient comes to you initially, the modalities should always include non-operative options, which is NSAIDs as the drugs. You could also do exercise, which includes lumbar flexion based exercise, because in patients with flabby muscles, for example, the increased extension force due to the lumbar lordosis and also the weakened abdominal muscles due to the huge belly will cause abnormal balance, abnormal forces along the lumbar spine, and so forth. You need to strengthen the lumbar flexion muscles so that a balance is obtained. Other exercises that could be done include the core strengthening exercises or the hamstring stretching exercise. Well, even if these methods seemed trivial at first, patients who are routine enough in doing exercises, core strengthening, focusing exercises, usually can get better in time, in terms of months or years. And even if the effects may not be permanent, it may be enough to prevent them from undergoing unnecessary surgeries. Well, even if it seemed to be tempting to avoid surgery, sometimes surgery is still needed. In cases of failed non-operative treatment, in cases with progression of the slip that is evident from the X-rays, and also patients presenting with an emergency such as neurological deficit or cauda equina syndrome. Well, the methods of the treatment are most likely the same because low-grade slip can be treated with direct posterolateral fusion in situ, and high-grade slip can be treated with posterolateral fusion up to the L4. Always remember that reduction in a high-grade spondylolisthesis is quite dangerous because it carries the possibility of a L5 nerve root traction injury if performed. And that is all for the adult isthmic type. Moving on to the degenerative type. Well, for the degenerative type, the etiology may be slightly different because patients come at a late age, and it is usually due to an anatomically different variance because the facet joint may be more sagittally oriented, and therefore the bones or the vertebrae may sublux forward in a higher prevalence. And besides that, the diagnosis are basically the same because patient may come with a mechanical back pain or stenosis over at the posterior region. Well, stenosis is more frequently found in this age population, mainly due to the degenerative changes that occur all around the spine. I will cover about the lumbar canal stenosis in other videos posted in the playlist. For the central stenosis itself, patient may present with neurogenic claudication, while for the lateral recess stenosis, patient may present with nerve root compression. Well, the physical findings usually varies. It varies because the level of spondylolisthesis may determine the nerve root that is involved, which could be L4 or L5. And other findings may include hamstring tightness, or a test could be done to provoke the patient. It is called the provocative walking test. The patient is made to walk a prolonged distance until the onset of buttock and leg pain, and then we have the patient stop but remain standing upright. If the patient have resolving pain, then the condition is usually caused by vascular claudication. But if the patient sit and the pain then resolves, the condition is caused by neurogenic claudication because sitting changes the position of your spine and therefore the diameter of the spinal canal, and therefore relieve the neurogenic claudication. Well, the classification for this condition can be made based on the instability classification scheme. So in this study, the spine is divided into three types, which is the stable type, the potentially unstable type, and the unstable type. And the parameter to determine which category our patient is in is based on these four parameters, which is the low back pain, the restabilization signs, the disc angle, and the joint effusion. If the patient presents with none or very mild pain, then the category should be stable. And if it is in the primary or secondary complaint, it is a type 2. And if the low back pain presents as a primary complaint, then it is a type 3. For the signs of restabilization, you need to know that a stable spine is seldom painful, but an unstable spine can present as a painful case. So in a type 1 case where the spine is stable, there should be restabilization signs with grossly narrowed disc heights and stiffening of all those tissues around the spine. While in the unstable type, usually we cannot see any restabilization signs, and the spine may have normal to slightly reduced disc height. For the disc angle that is involved, this angle should be lordotic with a greater height of the disc at the anterior aspect as compared to the posterior aspect. We call that a lordotic disc angle. And in a stable spine, usually the disc remains lordotic on flexion radiographs. Other parameters that could be used is the measurement of the translation on dynamic films, and it should be less than 3 millimeters. As for the unstable spine, during a flexion radiograph, the disc angle may appear kyphotic, with increased disc height posteriorly as opposed to the anterior disc height. And there could also be translation of even more than 5 millimeters on dynamic film. Other parameter that could be used to evaluate instability is the joint effusion. As you can see here that in the unstable type, we could see a large facet joint effusion on MRI, while in the stable type, the MRI may reveal no facet joint effusions. Well, after you know that the patient can be classified into these three groups, we move forward to the treatment, because you need to know that the treatment is based on the condition of the patient. If the patient is still in a grade 1 type of stability, then treatment should always include decompression alone. But if the patient has a grade 3 type of stability, then decompression and posterior fusion or interbody fusion should be performed to provide relief of the nerve compression along with stability, restoring the stability of the spine. Well, the non-operative treatment for the spondylolisthesis in the degenerative type is mostly the same, which includes NSAIDs or core strengthening and should be used as an initial treatment, but the operative ones are indicated only in certain cases where non-operative modalities have failed and there is progressive neurologic deficit along with a cauda equina syndrome. There are various methods of performing this surgery, but most of them will include nerve root decompression with or without stabilization through fusion, and the fusion itself could also be performed with or without instrumentations. Well, the complications usually are higher in the elderly population, not only due to the age, but due to the anatomical changes and the body's compensatory capabilities. Well, pseudoarthrosis can occur if the fusion is failed, and adjacent segment disease may occur because when you fuse a certain segment of the spine, that whole segment becomes stiff, and the junction between the stiff area of the spine with the mobile area of the spine may cause a trigger point for another condition, another pathologic condition, another degenerative condition, or even for further slippage. And these are called the adjacent segment disease over at the adjacent segment from the initial pathology. Other complications which may arise include the surgical site infection, the dural tear, or even positioning neuropathy, which may occur due to the positioning of the patient during the surgery. Usually the patient is positioned in a prone position, and therefore dependent areas of the body must be protected at all times. That would be all for today's explanation. I hope you enjoyed this video. Please look around for the previous spondylolisthesis video, the part 1, to understand the basics before you go through this video. Thank you for watching. Don't forget to subscribe to Orthopedic Tutor.